So broadly speaking, you can say you've got three groups of things. You said one is peptide, second is steroid group of hormones, and third is amino acid derivatives. So what is the basic difference in terms of three things I'm asking? One is about their effect, duration of effect, and the specificity in that regards to various tissues. So steroids would be generally
shorter acting.
no, they will have a longer duration of action, because that we'll discuss about that, because they will be binding to different sort of globulin. So they will have a longer duration of action. Most steroids, except for let's say cortisol and aldosterone, will have a long-term effects in terms of reproduction, in terms of other aspects as well. Amino acid derivatives are the shortest acting. So they will have quick, you will have norepinephrine, epinephrine, thyroxine, they will have a quick effects. Peptides are a different class of hormones. They are the most difficult to produce. So you will have a large molecule which has been produced, and it will have a shorter half-life. So if you know a particular structure, you can predict how it goes from that perspective in that regards. So when we talk about endocrine physiology, the hormones basically are either peptides, and peptides we can have small peptides. Typically the hypothalamic peptides are the small peptides. Which is the smallest hormone you know of? Okay, how many amino acids? So TRH out of the peptides is the smallest. It has got only 3 amino acids. Why is it relevant? Because if you are so small, you will cross through the placenta. So it crosses the placenta freely from that perspective. Again, if you talk about AVP, it is a nonapeptide. So you will have around 9 in that perspective. So many of them, ACTH is a bigger one, but it is still not very, very big or complex compared to the other hormones. So most of the hypothalamic signals, if you talk about, they will have a smaller peptide from that perspective. Now, if you talk about the pituitary ones, they usually become more complicated and they become bigger. So when they become bigger, there are two types of hormones. One who have got a single chain, in which you have a disulfide bond within the single chain. Typical example is growth hormone, prolactin. So growth hormone, prolactin, human somatomamotropin, they are all structurally similar. And then you have got multiple chain, which will involve, usually you will have 2 chains. Now, what is relevant is TSH, LH and FSH. What is common to their structure?
Similar alpha glycoprotein.
So same, you have got not similar, same. The alpha subunit is same, and beta is also quite structurally similar. So that's why you got an overlap effect. Can you give an example of overlap effects?
So like if we have high TSH, then it acts on the FSH and it can cause the bleeding in the buds.
So primary hypothyroidism, high FSH will cause peripheral precocious puberty and ovarian cyst in girls, macroorchidism in boys. If you have a high HCG in pregnancy, what does it do?
It can act on the thyroid. And
it will act on the thyroid, on the TSH receptor to cause thyrotoxicosis, or every patient who becomes pregnant, your TSH will go down. On an average, the TSH goes down by 1 point. That is because of the HCG effect. So this is the importance of overlap in these 3 hormones. Insulin and IGF-1. What is the similarity and dissimilarity between the two? Both are 2 chains. So you will have A and B chains, and then they will be connected. You will have a C peptide which will connect them. But what is that similarity and difference in insulin? So let's say physiologically, what do you think is the similarity and differences in insulin and IGF-1? Insulin is predominantly for what do you produce insulin? It's a hypoglycemic hormone. And what about growth?
Promoting.
It increases growth. IGF-1 is primarily a growth promoting therapy, but it also causes hypoglycemia. So insulin and IGF-1 are actually structurally similar. That's why you say insulin-like growth factor. Their receptors are also similar, but the way they act is one of them has a predominant effect on the MAP kinase pathway. The pathway which is basically responsible towards growth, cellular growth, physiology in that perspective, while insulin is largely driven towards the hypoglycemic pathway. So that is the difference, but otherwise they will have an overlap. So structure can really predict a lot of functions in that perspective. Which is the hormone which is very similar to AVP? Talking about structure similarity. So oxytocin and AVP are actually same hormones, maybe a few million years ago in terms of evolution. Then they were split into two parts, and then you've got very small structural change which is there in that regards. So peptide hormone generally are more complex as compared to the steroid hormone, which of course you discussed already. You have got glucocorticoid, mineralocorticoid, androgens, estrogen, progesterone. These are all various forms of steroid. The most important steroid is
For our body.
the most important steroid is progesterone, because without progesterone, you won't have any continuation of the pregnancy. You may have zero cortisol, you may have zero aldosterone, doesn't matter, zero DHEA, the child is born with CAH, child is born without adrenals. But if there is no progesterone, there will be a miscarriage which will happen very quickly. So steroid hormones are there. Then, of course, you have got the amino acid derivatives, which are actually more like neurotransmitters. So they are like neurotransmitter, epinephrine, norepinephrine. So these are actually neurotransmitters in itself, norepinephrine. Thyroxine is also structurally similar. So now we will see how structure determines the action. And a lot of these things you can predict based upon their structure. So peptide hormone typically would be a hydrophilic hormone. So they will be able to basically go through the blood because they can swim in the blood. They don't have a problem. So what does it mean? They don't need a binding protein. Now, which peptide hormones have a binding protein, Dhwani? So that's an exception. There is a growth hormone binding protein which we discussed yesterday, which is actually the extracellular domain of the growth hormone receptor. Its action is different. Its action is to target it. Suppose you have got areas in which bodies, so we discussed last time, that the differential effect of the hormone depends upon the receptor. Whole body is bathed at the same concentration of growth hormone. Tissues which have got a growth hormone receptor will basically have more effect. Otherwise, you will not have an effect. Now, what does growth hormone receptor does? It's like a bait. The tissue which is growth hormone responsive, suppose a growth plate, it will throw growth hormone receptor extracellular domain outside. It will take the growth hormone towards its side and land it up on that regard. So it's something like that in that perspective. So it's more of a directional agent. It is not essential for growth hormone functioning. Which other important peptide has got a binding protein and which plays a very important role physiologically? And that also tells you that it is more of a paracrine factor rather than an endocrine factor primarily. We said that for paracrine, you want to have a binding protein which basically keeps it within that particular environment. So growth hormone has, but IGF-1 is very important. And IGF binding proteins play a very, very important role in terms of growth physiology. We said that if you have insulin resistance, your IGF-BP levels will decrease, so free IGF-1 levels will go up. This causes increased growth. This causes increased ovarian growth. So this causes relative tall stature in obesity. This causes hyperandrogenism in PCOS. So this insulin resistance indirectly is acting through that. So that binding proteins become important from that perspective. So there is a limited binding protein. But because peptides are there, and I'll talk about this a bit more, that peptides are generally there for rapid action. They're not for long-term action. Even if we talk about growth hormone comes and goes. It's in pulses. It's not that you keep on growing continuously. Because if somebody is continuously growing, there will be two things which will happen. One, there will be desensitization. And we'll talk about how this desensitization happens. There's a very, very unique mechanism which actually stops the effect of growth hormone as well. Because you don't want sustained growth hormone effect that will cause more tumor growth, neoplasia and all. So these are usually short acting. So when you say short acting, why are they short acting? How will you make a hormone short acting? So they will be lost, but yes, so they have got a lot of enzymes. So there is peptidases which are there in the body. So generally protein is a foreign substance. So body will say, okay, digest whatever protein you take, orally also you will digest, blood also peptidases are there. So you have got specific peptidases like we say DPP4. When we talk about GLP-1, for that you have got DPP4 which is there. There is vasopressinase which is there for vasopressin. So all these peptidases are there which will within a matter of minutes remove that particular peptide from there. So theoretically, they have a shorter half-life, much shorter half-life because they don't have a reservoir. where they can sit down. So there's no resting place. They will continue roaming here and there. They will go to the target tissue or they will be destroyed by these enzymes in that regard. So they have a short half-life. And then, of course, because they are essentially hydrophilic and lipophobic, they cannot enter the cell. So the way they can signal that way, and we'll talk about signaling and other things probably in the next class because that's the final important part in that regards, it will happen through an extracellular receptor. So this is a general principle when you talk about peptides in that perspective. This is what we've discussed last time. There is a big overlap in complex hormones like LH, FSH, HCG, and TSH. All of them have got same alpha units. Their beta units are different. Their half-life is also different. Why? How does body decide your half-life becomes more? So some of them have a half. Which one of them has a higher half-life? Highest half-life. No. So what do you use pharmacologically? HCG. So HCG you give it alternate days, so it has a long half-life. Why? So it is the post-structural modification. It's not just what the protein that the body is produced, how much it is glycosylated also determines the half-life. So if some structure is more glycosylated, the half-life becomes more. So HCG is actually a longest one because it's got the maximum glycosylation. LH is having the lowest, so LH has got the shortest half-life. Now, when we talk about, and this I ask every time, is that when you have the same regulator, GnRH, which is regulating LH and FSH both, you expect that if GnRH goes up, both should go up together and the level should be similar. How do you have a differential level of LH and FSH with the same dose of GnRH? Because of one, the half-life is different. And second thing basically is that there is a effect which is there in that perspective, which is there in that regards, which is about the half-life aspect and the pulsatility of GnRH. If your pulsatility is more, it favors LH predominant response. If pulsatility is less, it will favor more in terms of the FSH response. So why? With a single central regulating factor, you have got a differentiating response. The two reason is the half-life is different. And the second is that your pulsatility determines whether you have a LH or a FSH predominant response. So this is what I already discussed, that if your TSH becomes too much, it will act on the FSH receptor to cause peripheral precocious puberty and ovarian cyst in girls, von Wieck-Grumbach syndrome, and it will act on the testes to cause macroorchidism, which will be associated with you will have macroorchidism with no pubic hair growth. So this is the opposite picture. Now, why do you not have a pubic hair growth in von Wieck-Grumbach? So TSH is acting on the FSH receptor. So that's why you have got more growth, but your pubic hair growth is not there. Right? Or even the ovarian androgens. So there are two things. It depends upon the adrenarche. Now they have a delayed bone age, therefore the adrenarche will be late. And second point would be that they will have a hyperprolactinemia. And if you have hyperprolactinemia, what will happen? LH will come down. So that's why you do not have pubarche, which happens in this scenario, and you only have a thelarche and menarche. That same thing happens here. You've got large testes with no pubic hair. The opposite of this is adrenal etiology, CAH or adrenal carcinoma. You've got pubic hair, but small testes. So I think you can correlate from that in that regards. Now, placenta produces HCG, which we discussed, and this HCG will then act on the TSH receptor and it will cause increased thyroid production. So pregnancy is a hyperthyroid state. You have to basically cut down the cutoff by 1 in that perspective. So a TSH level, which is more than 4, is considered to be significant in pregnancy. That is because of this TSH overlap which happens in that regards. And HCG can also act. So HCG is basically like LH. So HCG will act on the testes to cause what is known as a HCG induced one, in which your Leydig cells will go up. You will have peripheral precocious puberty. The testicular volume will be intermediate. Why? So when you have three conditions, one is CAH, second is central precocious puberty, and third is HCG. Why is HCG testicular volume? Typically 6 to 8 ml.
Because bleeding cell only contain 20% of the testicular volume.
Mhm.
So if it is a SCG producing tumor, then it can cause only some.
So basically in the prepubertal stage, 70 to 80% is Sertoli cells. Pubertal stage, around 20 to 30% will be the Sertoli cells, then germ cells will come in. The Leydig cells will be around 10-20%. So that's why the volume, the upper threshold, the cap at which the testis can increase once you have a HCG producing tumor is around 8 ml. Anything beyond 8 ml means there is either a secondary central precocious puberty which has been triggered in that regards. So this is the LHXS. You have intermediate size testis in that perspective. So we've talked about peptides. Now we'll talk about steroids. Now steroids are opposite of peptides. They basically are fat soluble, so they cannot travel in the blood. So they need to basically have a boat. They need to sit on a particular boat, which is a binding protein, which will then carry forward. If you are in a boat, you are safer. If you're swimming directly in the sea, somebody will eat, some shark will eat you. Same are the peptidases, which is not happening here. So steroids therefore will have a longer half-life. That is the simple reason to understand from that perspective. So they have high protein binding and the enzymes can't degrade them. And therefore you have a high half-life which is there. Now the metabolic enzymes of steroids are usually located where? The metabolic enzymes of peptides are everywhere, usually in the blood, but for the steroids, they are there. So at the target tissue. So like we discussed, if you want to create testosterone, which is a pro-hormone, one tissue wants estrogen to form, so it will have aromatase there. The other wants DHT, it will have a 5-alpha reductase there. If you have cortisol, if a tissue wants to activate it more, it will have 11-beta HSD1. If there is a mineralocorticoid responsive tissue, it wants to suppress it, it will have 11-beta HSG2. So the steroid metabolism typically happens at the end organ level. Peptides are killed there only. So simply speaking, peptides do not require a boat or a ship to carry. That's why they are more at risk. Shorter half-life. Steroids need something to carry, longer half-life. Now, steroids will then go along with the binding protein. And this I'll talk about, that binding protein is not just binding it. It's modulating its effect. It's directing that particular compound to a particular region. And then it releases there. Now, steroids, of course, are, as discussed, lipophilic and hydrophobic. So they will clearly pass through the membrane. And therefore, their receptors are typically intracellular. But now there is a lot of, conventionally speaking, what we say, steroids act on intracellular receptor and have a lag time to act. Peptides act on the extracellular receptor and they act immediately. Why? How do you explain that? Why do peptides have an immediate effect while steroids have a longer duration effect?
Because peptide has a G protein coupled receptor, which act very fast.
So not only G protein, tyrosine kinase type 1. So how does it act fast?
Second messenger will be activated.
So what is the final effect? That's what I'm asking.
It don't produce any G.
That is the main thing. So for steroids to act, if you talk about intracellular receptor, you are talking about they are acting on the nuclear receptor, producing some gene. So what they are doing, they will act like a transcription factor. They will switch on, switch off genes. So it will take time. That's why you have a lag phase. While peptides, your structure changes. Immediately some channel will open up. Some enzyme will become more active. So that will have an immediate effect. So generally we say steroid, slowly acting, long half-life, intracellular gene product. Peptide, short half-life, immediate action, and that is because of the extracellular receptors. But now we know that there is an overlap between both actions. So it is well known that the extracellular receptors can sometimes be linked to what is known as a Krebs pathway, which controls the gene expression. And there are also membrane receptors which are there for steroid hormones. So steroid hormones can also have an immediate effect, and peptide hormones can also have a delayed effect, which is there. Which steroid hormones have got prominent membrane receptors? Yes, good. What else? Estrogen. So there they have an immediate effect on the membrane. So these are immediate effect which happens. So they don't need to wait for some time, few minutes to start acting from that perspective. Now, third group is very limited. So it's a amino derivative. They will immediately be produced, immediately be destroyed. So they will be like epinephrine, norepinephrine, or thyroxine. They will exclusively go through the circulation, and therefore they don't need a binding protein. They're so small also in that regard. They are degraded very, very rapidly by enzymes. They don't even have a minutes also. So they will go off from the system very quickly, which is important because their effect is even more immediate. So you don't want epinephrine once it's released to be there even for a minute or so. You will say you see a tiger in front of you, your epinephrine is there, you will run, fight or flight, whatever you will do. But you don't want that till half an hour your effect is there. While ACTH or growth hormone, the effect will be there for a few minutes. So you want ultra short half-life for these hormones. Now the effect again is typically membrane. So epinephrine, norepinephrine are membrane, and thyroxine is mainly an intracellular receptor. Now thyroxine, is it lipophilic or lipophobic? That's lipophilic. So how is it going in that? Okay, that's not true. Binding protein of thyroid is more of a reservoir. It's like a factory. It can move without the binding protein. So what I'm trying to say is that it is actually a hydrophilic lipophobic hormone. So how does it go inside the cell? So there is a specific transporter there. So there is a very unique situation. We said peptide cannot cross. They will say, okay, you don't have a visa. You stay outside. We'll take your message. These steroids, they are like, they don't need visa. They will come inside. And for this is special royal guest. You send somebody outside to take him inside. So they will actually bring it through. And that's why you have a transporter for thyroxine, which is there in that regard. So just to compare, peptides are usually large. They have got a less amount of protein binding. They don't bind to the protein with the exception of growth hormone and IGF-1. They typically have a membrane receptor with rapid metabolism. Steroids have an intermediate size. A lot of it is protein binding. They usually have an intracellular receptor. Rarely for estrogen and calcitriol, you have a membrane receptor. Their metabolism is slow. Amines are very small. They have got limited protein bindings. They are very, very rapid and they will be metabolized immediately in that regards. And therefore, the half-life will be very, very short. And the effect also will be rapid in that regards. So now if you look at it, what things does steroid control typically? What processes does steroid control?
Yeah,
what body processes are controlled by steroids?
The long-term process, like growth, puberty.
So growth, where does steroid control growth?
Sorry, like puberty, reproduction.
So reproduction, puberty, overall metabolism, all those things, these are long-term goals. So you don't have to worry quickly. Yes, you have some responses acutely like aldosterone, which will have an immediate response. Hypoglycemia, cortisol will come into the picture. But generally, they are the long-term processes. Peptides, you're talking about, they are controlling?
Glucose, calcium.
So you are controlling the calcium, PTH. It has to come in immediately into the picture. You're talking about TSH. So thermogenesis will be there. AVP, sodium regulation. So they are all acute, with the exception of maybe growth hormone. That's a different thing altogether. But generally, we're talking about peptide regulating short-term processes. They are regulating the long-term processes in that regards. And these are the ultra short acting. So there are three different ways you can think of. So one are, let's say you are fighting a particular battle. So you will have people, soldiers who are there, foot soldiers who will immediately go and fight. They are more like amines. Then you have peptides, which are already there in the body. Now that's important. They have to be there. You can't basically produce now. Suppose you want to create a big aircraft carrier or something, you can't create it immediately. It has to be there. So they will be stored there. While steroids are more like you are producing things which are on a regular basis, but they are for a long-term basis. You are creating more bullets. You are making those sort of things.